Good morning, everyone in Nepal, and good evening, everyone in Canada. I would like to welcome you all to our sixth session of Pediatric Palliative Care ECHO, and we are almost midway of this Pediatric Palliative Care ECHO II series. For today's program, as usual, please keep yourself mute unless you are asked to speak or unless we are in discussion. And I hope that you all are using your own name for the purpose of attendance. Today's session on pain management is going to be more interactive, and I think that you have all gone through the case scenario that we have shared you in the WhatsApp. Please be active in the chat, and we will be clearing lots of our doubts in this session about the pain management. For today's program, I am Dr. Sudhir Sapkota, and I'll be the facilitator for this program. Saskriti will be the host and Chak will be co-host for today's program. And for the question and answer and chat, Mohammad Isaac and Megan will be available along with all other faculties. Sunny and Saskriti will be the timekeeper for today's session. And at the end of today's session, Dr. Sushma Gurung will collect the key learning points. Let's begin our program with the first session on pain management in children at hospital and at home. For this, I would like to welcome Dr. Megan, who is known to all. She is a pediatric palliative care physician based on Ottawa, Canada. She has extensive experience working in Bangladesh, and she has led multiple online projects to capacity building for pediatric palliative care in South Asia. It's over to you, Dr. Megan.
Thank you. And Sudhir, just about how long should I speak for? When should I stop, just so I know?
You can take up 30 to 35 minutes, Dr. Megan.
Okay, perfect. Thank you. So namaste and good morning to all. And we're going to talk, like Dr. Sudhir said, about pain management, but in a very practical way. So you've seen the video and the case from the video that Dr. Ishak had prepared online for us. And so then we're going to build on that and really show in the case how we do it in a real situation. So I think after today, my goal is that you can choose an appropriate pain medication and develop a pain management plan for a child with cancer. Start opioid treatment safely and titrate appropriately, and prevent and manage any opioid side effects. So just as a reminder, I put a few slides to just remind us of the key points. So remember, for children, we use the two-step WHO pain ladder. Step 1, if they have mild pain, which is 1 to 3 out of 10 on the 0 to 10 pain scale, then we can consider paracetamol or ibuprofen. Although ibuprofen we don't use very much in children with cancer because of its effect on the platelets. But occasionally in children who are at the end of life, who don't have leukemia, who aren't taking chemotherapy, there is a role for ibuprofen. So sometimes you do end up using it, but it's more limited. And then for step 2, as you can be reminded, moderate or severe pain, so 4 and above, then you go for morphine as your first line medication, oral morphine. And second line is any other strong opioid. So those would include like fentanyl, methadone, oxymorphone, oxycodone, any of those. And the ones we avoid, as Dr. Ishak told us in the video, is tramadol and codeine. So those are not good. We don't recommend them for children. And then we can always have under consideration any other modalities that might help, like radiation or nerve blocks. And there are select cases where these are very helpful. We should always use our non-pharmacological strategies, and we should also remember to manage other symptoms, because sometimes the pain is heightened by the nausea or the anxiety or the lack of sleep, and we can manage those. So how do we select between different strong opioids? So we would say that morphine is the first line opioid for all children. There is no evidence to recommend any alternative opioid in preference to morphine. So we think morphine is as good as anything else, and we have the most experience with it, and generally it is the least expensive opioids. So it's a good choice for our patients. We remind ourselves that different individuals will respond to different opioids in different ways. So sometimes we need to increase the dose because the patient doesn't respond in the same way as another patient. And sometimes if we have the option, we may need to change opioids. But my experience overall is that with oral morphine, we can manage at least 70 to 80% of the children with pain. And in Bangladesh, we never had anything beyond oral morphine, and we managed everyone with that. So it is possible to do a pretty good job. And we know that we prefer the PO route, but sometimes subcutaneous or IV is good if the child can't swallow or there's an acute pain crisis. And you'll see all this in the case. So in the hospital, when we're titrating opioids, we can titrate as rapidly as is practical for us. So sometimes we do a morphine trial where we titrate, we give a dose every 15 minutes or every 1 hour until we find the dose, and we monitor the patient closely. We can also titrate every 4 to 24 hours just by coming back and checking and giving the patient another dose. At home, more likely we would contact the patient every couple of days to titrate. So if the patient is having a lot of pain, it's more difficult to manage that at home. We always start with the short-acting opioids, and then we switch to the long-acting ones when we have stable pain control. So in Nepal, you have a short-acting form of morphine, both oral tablets and oral liquid, remember, and then you have 2 long-acting formulations. Those long-acting ones, I will show them to you, they should last 8 to 12 hours. So they're different than the rapid. And we also have the option of fentanyl patches in some countries, and those can be used after, again, you have a stable dose of opioid, of morphine that the patient's on. So let's go straight to a case that uses all of these points and a few more from Dr. Ishak. So this is the patient that you have seen. We shared the case on the WhatsApp group. You're caring for a 14-year-old boy who is newly diagnosed with osteosarcoma. While admitted to the oncology ward, he develops sharp pain in his legs. He rates the pain as 3 out of 10, and it's constant. His weight is 32 kilos. How would you manage his pain? So I know you've seen the case, so I want people to share in the chat, please. What would be your treatment? Just write it in the chat, and I'm going to call on a couple people to give some comments as well about what they think would be the best options. So maybe can I hear from Dr. Tiwari? Do you have any thoughts about what we could do? What pain medicines? Oh, perfect.
Yeah, I would like
Go
to
ahead.
prefer acetaminophen or oral acetaminophen.
I agree. And a few other people have written that. Paracetamol or ibuprofen, acetaminophen. Yeah. Good. Yeah. So he has 3 out of 10 pain, right? So that's our first step on our pain ladder. Anything else that you might consider at this stage?
Other than this medication, we can go for non-pharmacological approach.
Great. I'm glad you mentioned that. So we can go for non-pharmacological approach. Sometimes that involves like just seeing how he's coping with being in the hospital. Is he stressed? Is he anxious? Helping answer his questions about what's going on. And maybe at this point, we're not going to disclose the diagnosis because it's very new and we're maybe not ready to do that. But at least we can help him understand a little bit what's going on, answering his questions. Because sometimes the pain is heightened by anxiety, right? So we have to manage that too. Good. So let's see, what did I say? So I said paracetamol, 500 milligrams every 6 hours. So for me, in my situation, I usually use 15 milligrams per kilogram per dose of paracetamol. Some people have used more like 10, but you can use up to 15 as long as you just give 4 doses per day. So I thought in this case, 15 per kilo would be good because probably he actually has quite a bit of pain. And sometimes what we find is teenagers underreport their pain. I typically dose them just a little more aggressively. I also thought that in this situation, you might consider adding SOS breakthrough morphine, which you could have available in case he needs something in case overnight he has more pain, he has a pain crisis, because I suspect that he's going to have more pain, right? He has an untreated osteosarcoma. It's going to be fairly painful. So you wouldn't be wrong to give him oral morphine, 0.2 to 0.3 milligrams per kilo every 4 hours as an SOS, or IV morphine. So if we do that, let's look at the calculation for the morphine to just show you exactly how I would decide on the dose. So oral morphine, I said, okay, if we give him 0.2 per kilo, that times 32 kilos, that equals 6.4. So looking at this bullet, you could give him 6 milligrams of oral morphine as a syrup, or you could give him a 10 milligram tablet. Okay, I think it would be reasonable to give him a 10 milligram tablet, in my opinion. I would feel comfortable doing that because your options are syrup or tablets, and you don't have 5 milligram tablets. And I think 5 milligrams is not enough. So I would go for 10 milligram tablet. If you give IV or sub-Q, which is probably not necessary, but just so you can see what the dosing would be, it gives you 0.1 per kilo, 32 kilos, you get 3.2 milligrams. So I would round to 3 milligrams. Okay, I think it's very reasonable to round to 1 decimal place. And you can see that for SOS, IV or subcutaneous morphine, every 2 to 4 hours is reasonable. So remember, you have oral morphine syrup in Nepal, apparently since 2009, which is great. It's nice that you've had it. And it's 2 milligrams per ml. So, and you get a 60 ml bottle. So you don't get very much in one bottle. You only get 120 milligrams of morphine in a bottle, which in some patients, that's 1 day, right? Or even if they have a lot of pain, you could use that in less than a day. So I sometimes find that if the child can swallow tablets, the tablets are a little bit more practical because you get more tablets in a box. So let's look at what happens next. So next, you review the patient the next day on your rounds, and his pain is much worse. And now he rates it as 6 on 10. And you had given him the breakthrough morphine and told him like if he needs it, he could take it, but he doesn't take any, even though the pain is now 6 on 10. And his pain is so much he can't weight bear, he can't walk to the washroom. He's really uncomfortable. So what should we do to manage his pain at this point in time? Again, I think if you want to write in the chat, that would be really good. So write exactly what medicine you would prescribe, like how you would write it in your chart, in your orders, however you do it. Good, and I see a few people are starting to write things in the chat. That's great. Syrup morphine, 6 milligrams every 4 hours, or oral morphine every 4 hours, 6 milligrams. Exactly. So it's exactly what we said, right? You can give him 6 milligrams if you want to use syrup. You can give him 10 milligrams if you want to use tablet. Because he's 32 kilos, if you do 0.3 per kilo, you get 9 point something. So you would not be wrong to do 10. I think if he's like a normal sized kid, he can probably handle 10. You could also give him a dose if he's in a lot of pain of 3 milligrams of IV or subcutaneous morphine, what we would call a stat dose, where you ask the nurse to give it to him right away so that the pain is managed. Melanie's saying you could also give him 1.5 tablets or 7.5 milligrams. That's a great suggestion. But the tablets at Melanie are 10 milligram tablets. So you'd have to give him 3/4 of a tablet. So I'm not sure if it's possible. Is it possible to break your tablets?
Sorry, I thought they were
in
5
half?
milligram tablets.
Sorry. Oh, sorry. Yeah. They're 10 here, unfortunately.
Sweetie.
Sorry, I missed that. Go ahead. Somebody was saying something. Okay. So syrup is good. The main issue I find with the syrup is that you go through the syrup very quickly. But it's also reasonable. So then what happens, of course, is that the mother has Googled the medication that you advise, the morphine, and she is worried to start the child on the morphine. So how do we approach the issue with her? So what things would you normally say to the mother if you're giving morphine? Someone's written in the chat, better to give syrup than break the tablet. Yeah, I agree. I find it is usually better. They're more able to manage it. Okay, why don't I call on Dr. Sudhir, do you want to suggest somebody who could help us answer this question of how do we approach the mother's hesitance with the morphine?
Dr. Sumit, would you like to answer that question?
Hello. I think we can counsel the mother and give her reassurance that there are not much side effects and how we can manage the side effects. I think that would be the approach that can help address the concerns that the mother has.
Thank you. And I see that Angela has written, he needs pain control and morphine is the most efficacious drug. It doesn't cause dependence or addiction. Good. So sometimes that's what they're worried. They've read about addiction, right? And they don't want their child to be like drug addict. And Dr. Natasha wrote, I often start by asking what her worries are and what she has read about the morphine. So that's a good suggestion to find out what she's worried about. And Dr. Tiwari wrote about nausea, vomiting, and sometimes can cause constipation, and those things are manageable. Good. Okay. Good suggestions. So I wrote the same things as you have written about it being safe and effective for helping children with cancer. We've used it for many years and we've used it in other patients. You know, if it helps if, you know, there's another, if you can say, I have another experience with this same medication, it worked very well for other patients. They were also worried, but once their child took it, they saw how much it helped their child. Sometimes we can emphasize that, you know, it's important that children have their pain treated. We really want to make sure the child is comfortable and is not suffering. And if they're worried about addiction, I usually explain it because it's a very big worry in Canada because there's lots of problems with opioid addiction. I say that if we're using it for pain, the medication goes to where the pain is being felt, goes to the pain receptors, and it just acts there. And so then they don't get addicted because it's really acting on the parts where they're feeling the pain. And it's different where if you take morphine and you don't have pain, then the medication gives you that really high feeling or a good feeling or something like that. Parents seem to understand that pretty well. I also think that when you're talking to the mother, it's nice to also just help them understand what are your expectations going forward, and the child too, because he's old enough to understand. Manage their expectations about what's going to happen next. So you could say, we expect that once we have started the cancer treatment, his pain will start to go away. Then we will reduce and then stop the morphine if he's feeling better. So you're telling her, how long are we going to give the morphine for? And we will monitor him closely for the side effects that Dr. Tiwari mentioned, and we can treat these. Some parents might be wondering about whether like morphine is going to hasten death for their child. I don't bring this up unless the child is in a more advanced stage of their illness, where the parents might be worried, is the doctor giving morphine and then, you know, it means he's going to die, right? And I always say to every patient in that situation, every family, I say, you know, this medicine is not going to change how long your child lives. It's not going to cause him to die sooner. This medicine will just make sure that he's comfortable, but it doesn't affect how long he lives. And I'm not trying to do anything to change that, and I won't. And again, this just shows you and reminds you of some of those common myths that people might have, or false beliefs about morphine, that morphine shortens life. We know that it doesn't. If it's used properly, it should have no effect on duration of life. That opioids sedate patients, but we know that sometimes people are a little more drowsy than when they start, but usually this gets better because they're more well rested and they're more comfortable, and then they can be as alert as possible. If patients are very sleepy or somnolent, it's usually because they have very advanced cancer, right? They will be sleepy because they have cancer, because they're dying if they're in that stage. Opioids are addictive. We talked about that. And this one is more for other physicians. So sometimes we face a situation where physicians don't understand the importance of treating pain. You know, there's still myths that, you know, children don't remember pain, especially babies, they don't feel pain, but those are not true. We know that children and even premature babies feel and remember pain. And I think it was great that Dr. Tiwari also mentioned the common opioid side effects, which we should mention to the patient. The most common one is constipation, then nausea and vomiting, itching, and sedation, like we talked about. So what could we do to help manage the side effects that the patient might experience? What medications would we have either SOS or would you start to help with side effects when you're starting morphine? What are the common medicines that you use for constipation management in opioids? Maybe Dr. Sumit, you can tell us again, give your ideas.
We can use lactulose for constipation.
Yeah, lactulose is excellent. It's the first choice, definitely. And what about for nausea, vomiting? What would you typically use first line?
Metoclopramide, because
Great, that's a really good option. Yeah.
because in Dr. Isaac's slide, he had said that metoclopramide is a better option than ondansetron.
Very good. I'm glad you picked up on that. Exactly. So yes, so metoclopramide, because it's antidopaminergic in the brain, it's a better anti-nauseant for opioid. Opioid-induced nausea is mediated by dopamine, whereas ondansetron works through 5-HT3, and so it's not effective for opioid-induced nausea. Good. And someone else has written, Srijana has written biscodal tablet. Yeah, you can definitely use that also. I don't know if you have Senna or Senasides. It's a stimulant laxative. It's very well tolerated, and I find it very useful also sometimes, but I usually use lactulose first. So you can always think about a constipation treatment when you're starting opioids. Now, I find in South Asia, people are less constipated than in North America. So I don't always start a laxative. I counsel them about laxatives and that they need to watch, but I don't always start it because I find people don't necessarily need it. But here I've used Senna, but you can use lactulose. Itching. So small children get itching. Some patients get itching with opioids. There's no perfect treatment for the itching. Okay, some people use antihistamines. It helps a bit, but it does actually kind of sedate the patient more than actually reduce the itching. Some people think that ondansetron might help with the itching, but you don't have a perfect option. But just watch for it, warn the patient about it. People are more tolerant of side effects when they've been warned that they might get the side effect. And then for nausea and vomiting, I would use metoclopramide or haloperidol and avoid ondansetron. And sedation, again, is just counseling the patient about it. For patients who are needing a lot of opioid because they have advanced cancer and they have a lot of pain, but they still have good functional status, like they still have quite a bit of energy, the child still wants to play, maybe still wants to go to school a little bit to see her or his friends, we actually use stimulants for that. So I don't know if they're available in Nepal. They were available in Bangladesh. They are methylphenidate, which goes by the trade name Ritalin. It's a treatment for ADHD. Do you have that, Sudhir?
I'm not quite sure, but I don't think so that it's available in our country.
Okay. Stimulants are not available. Okay. So it's good to know about it. Occasionally I have patients who are on a lot of opioid because they have a lot of pain and they get drowsy and they're annoyed by being drowsy. And I can give them methylphenidate and it gives them more energy and they're a little more awake. So it's a possibility, but it's just for you to know that it is being used in that way in some countries. So those were the side effects. I want to make sure you're safe when you prescribe opioids. So we just have to remember, what does opioid toxicity look like? Toxicity means you have too much morphine in the system, okay? The patient gets respiratory depression. They don't get dyspnea, they don't get breathlessness, they just get slow respiratory rate. They get constricted pupils. They might have myoclonus, which is basically just like sort of twitching of their muscles. Usually you see it in their hands and arms and feet. And they might be extremely sleepy. So the treatment for this is naloxone injection, given IV or subcutaneously, until they improve. And so naloxone lasts for 30 to 60 minutes. It reverses opioid effects. But opioids last for 2 to 4 hours. So you have to continuously monitor the patient and give more naloxone after 30 and 60 minutes each time. You have to keep checking the patient. I'm not going to go into that in detail. To be honest, I have never had to do this, and I have prescribed many patients opioids. But if a patient comes in and they've taken like 20 tablets, or they drink the whole bottle of morphine by accident, like another child does it, then this is the treatment. Okay, so here we are back at our case. The mother is satisfied with your explanation about the morphine, and she starts it. So the nurses give the child 1 dose of IV morphine to start with, and then 2 hours later, he starts taking 6 milligrams of oral morphine every 4 hours. He takes some lactulose for his constipation, does not have any nausea or itching, and his pain control improves. He's using 1 to 3 breakthrough doses per day. So how many SOS doses is okay to take in 1 day? What do you guys think? Is it okay to take 1 or 2 or 3? Would you change your pain management plan based on that number of doses? So 1 to 3 doses is okay. That's optimal. You can expect that in a 24-hour period, a patient with cancer pain who is taking regular opioids, meaning every 4 hourly, will need 1 to 3 breakthrough doses. People have studied this in the research. And even if they have good pain control, the patients still need 1, 2, or 3 SOS doses on average. And that's normal. So we accept that. If he was needing 4, 5, 6, 7 SOS doses per day, then we would take those doses and add them to his regular dose. Good. So people are saying in the chat, maybe 1 or 2, every 2 to 3 hourly between regular doses. Yeah. So remember that oral morphine takes like about 45 minutes to be absorbed and to have its full effect, right? So if the patient takes a dose, counsel them to wait at least an hour before they take another dose, okay? But if they're having a lot of pain and they take 2 doses back to back, they're going to be okay. They're not going to die. They're not going to have an opioid overdose. My patients take 2 doses 1 hour apart and they're fine. So we think about what else should we do for the patient at this time. So we've talked about opioids. Dr. Tiwari mentioned before about non-pharmacological treatments that we might help him. But we should think about if there's any other medical treatments that we would consider to add in addition to the morphine. Does anyone have any ideas for what we call adjuvant medications that might also help with a patient with a lot of pain? Good. So someone's written valproate, sodium valproate. Yeah, so that's an adjuvant medication. What other adjuvant medications do you have that you commonly use in Nepal? Good. Dr. Pradeep wrote pregabalin. Good. Yeah, that's another one. Yeah, so there's a few of these treatments that are available. Sorry, I'm going to go to here. So I think of them in these categories. You have your anti-inflammatory treatments, things like ibuprofen or other non-steroidal anti-inflammatories. You have treatments that maybe are what we call neuropathic pain treatments. Gabapentin, pregabalin, valproic acid. These are medicines that we think have effect against neuropathic pain. You also have the option of steroids. So sometimes we give patients with advanced cancer steroids as essentially an anti-inflammatory co-analgesic effect. And then I want to mention methadone because it is something to know. I don't think it's available in Nepal, but it's good to know, okay, this would be another option. Methadone is an opioid, but it also has neuropathic pain properties and works on a variety of pain receptors. So these are some other things you can consider. So in this case, the child was given ibuprofen 400 milligrams every 4 hours and gabapentin 150 milligrams TDS. And you could also use pregabalin. In my situation, pregabalin is a lot more expensive than gabapentin. So I just use gabapentin because it's 10 times cheaper, but both are good. The other ones in this category would be like amitriptyline or nortriptyline. So he has his chemotherapy started and his pain control improves. You discontinue the regular morphine, but you continue the SOS morphine for a few more days, just in case he has some pain. When you see him, he has used 2 SOS doses in the past 24 hours. So you discharge him home 5 days later, and you just advise him to use paracetamol for pain at home. Okay, so if the patient's on pain medications for 5 days or less, you don't need to wean them off the opioids. You can just stop the opioids and just go to SOS dosing. And then if he just uses 1 or 2 SOS doses, great. And then when they discharge home, if they haven't used any SOS doses in a few days, you can tell them they don't need to continue with the morphine. If the patient is on morphine for more than 5 days, then we would advise to decrease it a little bit and wean them off of it over maybe 1 or 2 weeks, because they will be tolerant. And if they stop it immediately, they're going to get some discontinuation effects, meaning they're going to feel tachycardia, sweating, tachypnea, hypertension, and they can have, they will feel unwell. So they shouldn't go off it suddenly. So in this case, 9 months after that first episode, the patient has completed his chemotherapy, he had a surgical resection, and he was disease-free after completing 6 months of treatment. But as follow-up, he has screening imaging 3 months after he completes his treatment. So 9 months after he was first diagnosed. And that shows that the cancer has recurred in both lungs and in several spots in his bones, in his vertebrae and his femur. And now he is having pain in his back and his right leg. So you talk about it with his parents, and together you decide that he should try it for some oral chemotherapy with the goal of helping improve his symptoms and to give him more time. So we call this in North America palliative chemotherapy. Sometimes we consider it metronomic. We use the term metronomic therapy if it's very low dose in certain agents. But we use this in situations where this may help with pain. This will help him live longer, but we know it may not cure. It's not going to cure him. So then what happens is in the next few weeks, he's admitted to the hospital for symptom management because he has 9 out of 10 pain. So how would we manage 9 out of 10 pain in a hospitalized patient with advanced cancer? So we know we're going to use opioids, but because he's in the hospital and in this situation where he has advanced cancer and severe pain, I would generally give him a dose of IV morphine. And in this case, I might round up to 3.5 milligrams. And I talked about the monitoring here because I thought this might be important. We had some discussions about this, about how often do you monitor patients who are on opioids. It depends on your hospital. You should have a protocol. An example, this is what we do. We monitor every 15 minutes for 1 hour. If the first dose of morphine is ineffective after 15 minutes, we repeat the dose. And that's what we did in this situation. So we gave 2 doses of 3 milligrams, sorry, not 3.5. And so in total, he got 6 milligrams IV. And then we decided to start him on an IV morphine every 4 hourlies of 6 milligrams. You could also give 3 milligrams every 2 hours, but that seems like every 2 hours the nurse has to give an injection. So that's probably not a best idea. So I gave him 6 milligrams every 4 hours. I wanted to show you the example of how you would turn that into an infusion. So if it's 6 milligrams every 4 hours, then 6 times 6 is 36 milligrams in 24 hours. So you could give him 1.5 milligrams an hour. Or if you're putting it into IV fluid, you could put 1 vial of 10 milligrams of injection morphine into say a bag of IV fluid and give that over 6 hours. Usually, even if I'm giving an infusion of morphine, I also give an SOS dose of 3 milligrams every 2 hourly. So this is the injection morphine that's available in Nepal. I know this is not exactly the picture of it, but it's 10 milligram per vial. And correct me if I'm wrong on any of the opioids, Sudhir, but I got this from Dr. Bishnu. So after you give him the morphine infusion, his pain is 2 to 3 out of 10. And the next day when you see him, his pain is well controlled. So you decide at this point, you're going to switch him to oral morphine to see if he has good pain control with oral morphine. So if he's on 6 milligrams of IV morphine every 4 hourly, that equals oral morphine 12 to 18 milligrams every 4 hours, because the ratio for conversion is 2 or 3 to 1. So 1 milligram IV is 2 or 3 milligrams oral. So because we have 10 milligram tablets, I said, let's give him 15 milligrams. And he's comfortable with 15 milligrams oral morphine every 4 hours. I want to pause here because Dr. Sudhir has asked a really good question. We can repeat IV morphine after 15 minutes. We can repeat oral morphine after 60 minutes. When to repeat subcutaneous morphine if we can't control pain? I would do the same, 15 minutes. I think that's very safe and appropriate. So in my setup, I have a little electronic pump that I can program with the dosing. And I usually program it so every 15 minutes, the patient can push a button on the pump and they can get a dose of subcut morphine. And we have it connected to a little subcut site. It's like a sort of, it's like an IV. It's like very solidly attached in under the skin, like a butterfly needle, basically. And someone says we have 5 minutes more. Yeah, I think that's fine too. The most important thing is that you watch the patient and you re-examine them and you check on them. And you don't just keep giving morphine without checking to make sure the patient's awake, talking, breathing, but I think you can make a protocol. There's a bit of variation in this. 15 minutes is fine. 20 minutes is fine. And you have sub-Q syringe drivers. Perfect. Good. Good. So you have a similar setup. The thing with the syringe drivers is that typically, I don't know what yours are like, so I'm gonna ask about that after I finish my slides. But typically, they don't have the option to give an SOS dose on top of the regular infusion that's going on. But let's talk about that when we get there. I just want to finish this thought. Okay, so I had given him 15 milligrams of oral morphine because that was 1.5 tablets, which was easy, and that was working. In this example, if you have stable pain control, if his pain is good with 15 milligrams every 4 hourly and he's going to go home, you could switch that to long-acting morphine, right? Where you could give him 45 milligrams every 12 hours. But in Nepal, you have 10 milligram and 30 milligram long-acting tablets. So then I would just give him 40 milligrams every 12 hours, like one tablet 30 and one tablet 10, and see if that works. And if it doesn't, you can increase it. So there's two ways to increase long-acting. Sometimes we find that long-acting tablets, even though the manufacturer says it lasts for 12 hours, it only lasts for 8 hours. So you could, if 40 milligrams every 12 hours is only lasting for 8 or 10 hours, you could go to 30 milligrams every 8 hours, as an example. And remember that even if you send him with long-acting morphine at home, you should also send some SOS instructions. So the SOS dose is 15 milligrams every 4 hourly. These are your long-acting morphine in Nepal, 10 milligram PR and 30 milligram PR. These are expensive. So this may be, you have to think about the price. I'm talking a lot and I'm running out of time, so I'm just going to skip this. This is one useful graphic that we used in Bangladesh. And so I just want to highlight it because the mothers didn't know how to give morphine with a syringe. and we wanted them to measure the liquid morphine more precisely. And so in that situation, we made this small graphic that explains, like, pour some morphine into a small cup, then draw it up with the syringe, and then give it into the child's mouth and pour the remaining liquid morphine back into the bottle. So that's just a reminder that you may need to teach the mothers to do this. And it's because I know it comes with a little spoon, but it's really inaccurate. So we were never happy. We would measure the spoon and it would be like they were all giving different doses if they use a spoon. So I recommend for liquid morphine, you should use a syringe and just draw on the syringe a line where you want the mother to give the morphine, what volume, mother or father. Okay, I'm not going to go through all this, just to say you can also have some kind of chart where you get them to write the day and then to cross off each dose as they give it. And this one, you'll see this is for liquid morphine instructions. I want to highlight one thing that we can do is with the dose at night, you can tell them to take a double dose. Okay, so in many countries we do this because we don't want the patient to have to wake up at 3 a.m. to take their medicine. So we tell them, okay, 7 a.m., 11, 3 p.m., 7 p.m., and double dose at 11 p.m. And you can modify the time slightly if you want 6 a.m., 10 p.m., 10 a.m. You know, you can change these, but this was very practical for some patients. And you just have the sun on here so they get the idea of like when in the daytime. I think I'm going to skip this section because I'm running short on time and I want to be able to answer questions. So I'm going to go with just a summary here. So morphine, just to remind you, is our best option for moderate to severe pain, and we do prefer the PO route. I gave an example where the patient had a bit of a pain crisis, so we gave some IV morphine. It just depends on, do you have that option? Is it practical for you? Do you have access to IV morphine quickly? Is it possible to put in a sub-Q or an IV site? And in that case, it would be better because you can quickly titrate the dose, meaning you can increase until you figure out what's the dose the patient needs. In my case, I had to give 2 doses. After 15 minutes, I gave a second dose before we found the right dose for the patient's pain. We should discuss and manage the side effects, particularly constipation, nausea, itching and drowsiness. And we should make sure we counsel the patients and families about how to properly administer the medications. And when we don't have good pain control, we can titrate or increase morphine by 25 to 50% when the pain is not relieved. So I'll stop there because I'm sure that we can have a good discussion with questions from the chat, because I see there are a lot of questions.
Thank you, Dr. Megan, for this elaborative talk on morphine, and definitely there are lots of questions to be answered, and we'll be answering those questions in the chat. In the meantime, we'll move on to the second session as we are running out of time. And for this, I would like to request Dr. Bimala Bania present our case, which is also regarding the pain management.
Thank you, Dr. Shuler. Could you please share the slide? Yeah. Namaste, everyone. I'm Dr. Bimala Bania, currently working as a medical officer in Cantor Children's Hospital in General Ward. Regarding the key questions for my case presentations, it would be counseling and supportive care for child in pain and parents, rational use of morphine for pain management at home and at hospital, other modalities of pain management in pediatric care, and multidisciplinary approach for the management of pain. My patient he's a 5-year-old male, and he has been diagnosed non-Hodgkin's lymphoma, peripheral T-cell lymphoma, stage 3. He was diagnosed 3 months back, and this time he has other diagnosis, small bowel obstruction. This time he was admitted only for the chemotherapy. In his immunohistochemistry, he had peripheral T-cell lymphoma In CT scan, there were multiple homogeneously enhancing lymph nodes with hepatosplenomegaly with the differential diagnosis of lymphoma. And in bone marrow aspiration was negative for malignancy, and he was admitted for the chemotherapy this time. After admission, on the third day of admission, child developed abdominal distension, severe abdominal pain, and along with greenish vomiting. He also had not passed stool for the last 4 days, and he also had past history of the subacute intestinal obstruction 1 month back also, which was managed conservatively. So thinking that this time also he could have the abdominal obstruction, intestinal obstruction, so we did the basic investigations. In his investigations, we found that he had pancytopenia with the hemoglobin 9.2, platelet only 20,000, and ANC count was 840. His renal function test was normal, and he also had coagulopathy. So we did the, later the slide would come, we initially did X-ray abdomen erect. We showed the multiple bowel gas, dilated loops. There is a picture. We saw the dilated bowel loops and multiple bowel gas. NG was kept, and we did the CT scan. Then the CT scan showed abrupt transition of bowel caliber in proximal jejunum with proximally dilated small bowel loops, which was also in favor of the small bowel obstruction. So we promptly kept the child in nil per oral. His initial pain assessment was 8/10. So for the pain management, we gave him injection ketorolac, injection hyoscine, and injection morphine at the dose of 0.1 mg per kg 6 hourly. It was initially for his pain management, we only gave him injection ketorolac. We couldn't start with the injection morphine, thinking of its side effect as the constipation, and child was not passing stool for the last 4 days. So after adding the morphine, his pain assessment was 4/10 to 6/10. We couldn't increase the morphine dose, as I said earlier, considering its side effect of the intestinal obstruction. And we also gave him antibiotics, injection cefepime, injection metronidazole, and injection meropenem. And as it was the surgical case, so we did the surgical consultation. And as in their OPDM, as the child's condition was unstable, he was having pancytopenia, coagulopathy. So they advised to manage conservatively for the time being. They told to keep NG-free and the rectal wash was done, and the child was being managed conservatively only. Regarding his psychosocial and family concerns, they live in a nuclear family. His mother is a housewife and father is a farmer, and currently they have lost their job because they have to stay with the child, and they were worried regarding the management and the possibility of care of the child. Regarding the spiritual concerns they follow Hinduism and they have a strong religious devotion, and the child has low moral and he has fear of death due to the current condition of it. Child was aware of his disease condition. He complains of the pain abdomen, and he also wakes at night due to the abdominal pain, and he is very irritable, as we have kept him NPO as per surgical advice, and he talks with mother about his condition. We have done the multidisciplinary approach for the management of the child. We have consulted dietitian, and psychological counseling is being done with the expert psychologist. Surgical consultation is being done every day, and they are reviewing the child every day, and we are treating children by the reserve fund. So, summary of the case would be, we have a 5-year-old male child who is under chemotherapy for the non-Hodgkin's lymphoma, peripheral T-cell lymphoma, and he has developed small bowel obstruction that is being managed conservatively because of his unstable condition. Parents are worried for the management and probability of the care of the child. He complains of the constant abdominal pain and is irritated due to nil per oral. Curative along with palliative care was initiated. So my key questions are like, since the child could not undergo laparotomy and he was managed conservatively, was the main pain management adequate in our case? What was the best approach for the pain management in such scenario, and what else could have been done? Thank you. Waiting for your comments.
Thank you, Dr. Bimala, for this nice presentation. And definitely, it was a challenging case. So, first of all, I'd like to go with Dr. Mohammad Ishaq. Are these side effects, constipation, and the side effects of possible obstruction, are these correlated? Can morphine aggravate the situation of obstruction? Can you just share your views on that?
Thank you, Dr. Sudhir. Very nice case presentation. So morphine, whenever we put a patient on morphine, we have to be careful regarding the side effects. One major side effect being constipation. And like Dr. Megan has said, the first choice being lactose in most of the patients. And as our diets contain more of fiber, normally we don't have so much issues of constipation, but we need to be mindful, and we need to tell parents regarding what are the issues whenever we take morphine medication regarding the side effects. So when we tell them, when we give them guidance regarding the constipation, when we tell them to like use lactose, is to use a stimulant laxative. And if we are concerned regarding the child not passing motion, even with a stimulant laxative, we can give smoothing agent such as cremacin, and we can take it ahead. And if we are obstipation, whenever there is constipation and leading to obstruction, that is known as obstipation. So in that scenario, what we can do is we can use a dose of steroid as well as enema, like high enema or enema, so that the obstruction is released. So this is what all we can do in case of constipation and following constipation leading to obstruction. Any other comments, Dr. Megan, regarding it?
Yeah, Dr. Megan, would you like to add something?
Yeah, I mean, I think I would go for more morphine in this child IV because they already have an obstruction. So you can't make an obstruction worse. Like there's nothing worse than being fully obstructed. So the morphine is not going to make anything worse, right? Like you need these, I guess it seems like there's an area where the lymph nodes are enlarged and obstructing the bowel, if I'm understanding correctly. Correct me if I'm wrong. But morphine will slow down gastric and intestinal motility, but you already have motility of 0 because you have an obstruction. So if anything, slowing the motility might actually make him have less pain, because right now he probably has some intestinal motility, but it's like pushing against an obstruction. So I would go for a morphine infusion and just titrate until he's comfortable. And the problem is your surgeons. Speaking from experience, they're going to be like, no, you can't give him morphine. It's going to make it worse. And you're like, it's not going to make it any worse. He's going to feel better. So, but you got to work on the surgeons, which sometimes is possible and sometimes it's not. I used to have this problem with patients with Crohn's disease who would come in with really bad Crohn's disease with almost an obstruction of the terminal ileum, and the surgeons wouldn't want to give them any morphine, and patients would be in a lot of pain. Oh, good. And someone in the chat agrees with me. So I must be right. But is that right? The obstruction is, it looks like it's lymph nodes kind of causing the obstruction from what you guys can see on the CT.
No, it's not any lymph node or something like that. Actually, the child is on, I think, 3rd cycle of chemotherapy. We don't actually know the cause of the obstruction. Might be chemo related. We're not actually sure of that.
And did it just decompress with time? I know this case was, it was a couple weeks ago, right?
It decompresses with time. No need to operate the child.
Okay, possible adhesions. I don't know, it's unusual. Someone's saying possible adhesions, so. Okay, but I see Natasha's nodding her head and saying, yes, she would give more morphine too. So
I would definitely give. The other thing I was thinking about is a little bit of Dex. That might help with like if there's inflammation in the bowel. I mean, you need to see the oncologist for their problems here, because if it's a lymphoma, I don't know how much disease the child still has, right? And Dex treats lymphoma, so you would just have to ask the oncology team. Like I think if he's in his third cycle of chemotherapy and he doesn't have a lot of disease visible left, then it would be safe to give some Dex. Even a small dose, like 2 to 4 milligrams of Dex, I've used in bowel obstructions in oncology patients, and I do find it as a good adjuvant to increasing the morphine.
And Dr. Natasha, can you say what was DEX?
Dexamethasone, sorry, steroid. So I've used steroid, dexamethasone. I don't know if you have it available, but if you have any steroid available, it can help with kind of the inflammation in the bowel with an obstruction. So I have used it with good success.
Definitely, we do have dexamethasone.
Okay.
We
Yeah.
would have been used from next time onwards. And so any other for such type of spasmodic pain, any other pain management, any of the faculties would like to add to that?
I just have a couple comments. First is with an obstruction, we're concerned that there could be any sort of intervention that could result in perforation, and morphine is not going to cause that. It's not going to increase the risk of perforation. So I think it's completely safe to give. There's two other considerations which I'm not sure whether you have available. IV fentanyl does not affect the gastric motility as much as morphine. So sometimes I might use that as an alternative to morphine, but I don't know whether you guys have IV fentanyl. And the other medication for use with obstruction is subcutaneous octreotide. Again, I'm not sure if that's something that is available because that is very expensive.
So in case of such cases, we can shift to fentanyl instead of morphine if we have got strong objections from the surgeon. Is that right, Dr. Peter?
Yes, it is. It won't be a significant difference, but fentanyl is less constipating than morphine.
Yeah, definitely. Maybe we can convince surgeons for fentanyl rather than morphine. So it can also be a good option.
Yeah, it might reassure them if you're like, here, there's this other thing, and they won't know much about fentanyl, maybe, and they leave you alone. That's a strategy.
Yeah, definitely.
But it depends if you have IV fentanyl, because sometimes it's hard to get outside of the OR, right? Sometimes they have it for OR, but not for the outside world.
We can manage IV fentanyl in our place. So that will also answer our question about the best approach for pain management in this scenario. Now I would like to open the floor for discussion. Any questions from any participants regarding the case scenario or regarding the whole topic? Our faculties will be more than happy to answer that questions. Dr. Peter, would you like to elaborate about the sublingual morphine, how to use it in children?
So for very small children or sometimes babies who are who aren't able to swallow, we do sometimes use sublingual or buccal morphine because the volume is small enough such that you can put it in the tongue or in the cheek. However, the pharmacology of morphine when it's given sublingual buccal is different from many of the other sublingual meds. Usually when you give a sublingual med like lorazepam, for example, it starts to work in 15 to 20 minutes. But the problem with morphine is how it's metabolized after it gets into the blood. So it still takes 1 hour. So yes, you can give it sublingual or buccal, but you just need to understand that it won't work as fast as what you normally would when you give a sublingual med. So it basically is the same onset of action as giving it orally.
Thank you, Dr. Peter, on that. Any questions from the participants? Okay, then before we wrap up the today's session, Megan, would you like to add something, or have you seen any questions unanswered in the chat?
I was just going back and finding one. So I wanted to read out what Dr. Ishak wrote, which is whenever a child gets discharged and is off morphine, who was initially on daily morphine, it would be better to give some doses of morphine, SOS doses for pain crisis, as the child goes back home. So I think that's a very good point, to make sure you send your patients with a little bit of SOS morphine if they previously had moderate or severe pain. And in severe pain, should we always go for IV morphine, or can we trial oral morphine? And I think it depends on the situation. If the patient's calling you by phone and they're at home, go for oral morphine. If the patient's in the hospital, I prefer to give them one dose IV or subcutaneous if possible, and then achieve good pain control quickly, and then go for oral if possible. But it does give you faster, better pain control to give them IV morphine if they're admitted and they have an IV. And you can titrate it quickly, right? I gave the example, you can give it and give another dose after 15 minutes and see if then the patient has good pain control, especially for someone with 9 out of 10 pain who has osteosarcoma. Like, this is very painful. So it's nice if you can give them the IV option. Those are my only comments.
Okay, thank you, Megan. And I find that this has been a very interactive session, and still in practice, if we have any other queries, we can always meet each other in the chats, and our faculties will be available in the chat. Thanking you all for participation in today's program. I feel that from now onwards, we'll be more comfortable using morphine so that the child will be feeling better, and also will be able to convince our surgeons and our colleagues that morphine is the best drug for pain management, and it has very less side effects, and they are quite negligible as compared to the pain management achieved by the morphine. So with this note, I would like to end today's program. Hope to meet you all in the next session and next week. Bye bye, everyone.